Our first presenter, which is Christy Davis, who's a doctor of nurse practitioner and with metabolic medicine of Mississippi, will be our first presenter. So Christy, would you like to come on down? And with Ms. Davis is Whitney Herring, Dr. Whitney Herring, and she's the medical director, pediatric obesity medicine and nutritional program with the Mississippi Center for Advanced Medicine. So ladies, go ahead.
Thank you, Senator Blackwell. We appreciate this opportunity to come and talk to you about the challenges that we're having in our clinic and what we're seeing in our practice with the obesity epidemic. Like you mentioned or started talking about, we have a lot of, sorry about that. Can you hear me now? Between myself and Dr. Herring, we have a lot of experience in obesity, pediatrics, endocrinology, diabetes, and even with all of our experience, we are struggling to take care of our patients in Mississippi. There's a lot of times where I know we are sitting in clinics in our rooms and we're just handing tissues out and saying, I'm sorry, I can't help you. Even though we have the training, we have the tools that would be available, we don't have coverage and we don't have these tools available to us. So I want to start out by talking about obesity as a chronic disease. I think a lot of times it gets framed only as a lifestyle choice. But in 2013, the American Medical Board, American Medical Association, deemed that it was a chronic disease. It met all of the criteria for a disease that needed to have treatment and prevention interventions. What we find is our patients, by the time they see us, often have faced a lot of bias and discrimination regarding their chronic disease. What occurs is they have inferior health care and they then avoid health care altogether. So these patients have about a 93% of those patients affected by obesity have unmet medical needs. So that's where we get to a point, like you mentioned, hypertension, diabetes, and we start having other chronic conditions based on not taking care of this in the beginning, not having any prevention. Across the United States, our pediatric obesity rates are about 22%, a little bit higher in Mississippi. We are first in the nation for obesity rates in high school students at 23.5%. We are highest we have higher rates in our Hispanic and our Black population. Our highest rates of obesity is in our lower and middle income groups. There are multiple risk factors for obesity. Genetics, about 70% of our body habitus, whether that be thick or thin, is based on what we inherit from our parents, whether that be genetic or that be our behavioral patterns. Even maternal weight, pre-pregnancy weight plays a factor into a person's body weight for the rest of their life. We live in an obesogenic food environment. So for example, if I have a patient that is a single mother that has 3 children and 2 jobs, it's going to be very hard for her to go home every night and cook a very healthy, nutritious meal. So we're doing the best we can to meet patients like that where they are. Of course, sedentary behavior and other issues can cause this. Medications is a big driver of obesity. We think about things like steroids or patients that may have asthma and they're on steroids so they can breathe. That's a big promoter of weight gain. Also, psychiatric medications are a big driver in weight gain sometimes. We see that the psychiatric, the rates for anxiety and depression, especially in our pediatric population, is increasing. Those medications to treat that cause weight gain. Lack of sleep, and I put unhealthy diet all the way at the bottom because there's so many factors that go into a person's weight before we ever even think about what they've put on their fork. We know that obesity in adolescents has increased over the last 30 years by at least 15 to up to 30% in some studies. Obese adolescents risk becoming obese adults by 50 to 75%. And those adolescents that are obese grow up to be obese adults who grow up to have obese children. So we've got to be able to get in there and break that cycle somehow. We've got to be able to treat our pediatric population and our adult population. All right, so I want Dr. Herring to talk about some of her patients for just a minute.
Okay, so a big question is, can we lose weight with just lifestyle changes? And when I say lifestyle changes, I'm specifically referring to diet and exercise. So this is a patient of mine that I want to tell you about. It's a 17-year-old male who was extremely picky with his eating. I'm talking maximum five things that he would eat. He also had an elevated blood sugar. I was seeing him for about 3 years, and for those first 2 years of treatment, he continued to gain weight. We did multiple visits, saw dietitians. We even did very specific help with new food introduction, and he went up to 272 pounds. All of a sudden at 2 years, the light bulb came on and he was motivated. And so he started making those changes that we had been asking of him. He increased his physical activity. He accepted new, healthier foods. And believe it or not, over the past year, he's now at 171 pounds. So he lost 37% of his total body weight. And what means a lot to us is about 5%. If we can just get 5%, then that should be meaningful from a medical standpoint. But the usual weight loss with lifestyle changes is more like 10%. And the problem is that, yes, it's difficult in the beginning to lose that weight, but it's also hard to lose the weight because then mostly after a year or so, you start to regain that weight. So why is that? Well, you can see this sort of tug of war picture. And what happens is that our bodies really are programmed to gain weight, or they kind of have a set point. And what the set point is that our bodies have a weight that it wants us to be sitting at, okay? And what happens is when you start to make changes, you might eat healthier, you might exercise, but as you are losing weight, the body's hormones actually fight against you. So the hunger hormones go up, metabolism goes down. Those hormones that give you satisfaction, they also go down. So it really is this back and forth, and kind of explains why it's so difficult not only to lose weight in the beginning, but to maintain that. And like she said, greater than 70% of total weight is genetic or inherited. And that can be the kind of genetic obesity that runs in families. It could be something that goes wrong in the gene that then results in obesity. So I wanted to give you another example of a patient who we use medicine with. The first one we did not. This is an 18-year-old female with sleep apnea. This patient requires CPAP. So if she does not have CPAP, her oxygen levels drop extremely low at night, and this is very hard on her body, her heart, other systems. We have been seeing her for about 2 years. She had initially stabilized her weight with lifestyle changes, but then began to, increase again. So she started coming to me around the weight of 350. We started a medication to suppress her appetite, but we started a low dose. She continued to gain weight. She went up to 361 pounds. We finally got up to a maximum dose for her, and she started to lose weight. She's now down to 334 pounds. So I just wanted to give you an example of what medicine can do.
Passing the baton, thank you. And this graph here shows what the breakdown of the U.S. population looks like obesity-wise. And if you look at our Black females, 57% is quite a bit more than our 40% baseline that we have across the United States. The disparity is so great that the National Hispanic Caucus of State Legislators and the National Black Caucus of State Legislators have put forth some effort to increase states' ability to see that need to prepare for the next public health epidemic by addressing the high rates of obesity. What we saw with COVID-19 is patients that were affected by obesity were more likely to be admitted to the hospital. They were more likely to be placed on ventilator or life support, and they were more likely to die from COVID-19. And when we see a population that is disproportionately affected by that, that's where our concern comes in. They did include Medicaid in their call to action. So this is kind of where we've been and where we're going in the United States. We started out in 1960 tracking obesity. That's where I guess it started to, people notice that it was a problem, and about a 10% rate. I suspect that these are probably people that truly have genetic obesity. We see a little bit of an increase, and this is going to be y'all's fun fact of the day. So we see a little bit of increase, but when you get to the mid-1970s, that's where we start to see a big uptick. There's a theory out there that the 7-Eleven introducing the big gulp, the 32-ounce big gulp, does everybody know what I'm talking about? Before that, we had these cute little Coke bottles that were 6 ounces, that were 75 calories. That wouldn't matter if you had one of those every now and then. But now we've got 32 ounces or 350 to 400 calories with free refills. So you can see how that rate just goes straight up. We leveled off for a little while and then started uptick again. So we're up to right at a 40% rate in Mississippi now. Across the nation, that's pretty much the same.
I'm sorry. So is that big gulp theory? Is it a theory or is it fact?
I feel like it's a fact. What do you think?
Well, there's something going on from between 80 and 88 that did that. So
Seems likely.
I guess it's fact.
I feel like somebody from 7-Eleven is going to come get me
Right.
one day for repeating that, but.
So it's our culture that went to that, basically.
That's right.
Okay.
So we're looking at being up to a 50% obesity rate across the nation by the year 2030. So the scary thing is in Mississippi, our estimate is to be up to 66.7% by the year 2030. And I'll throw something even scarier out there. If we include all of our obesity rate right now, what we have in Mississippi, and we add overweight to that, we're at a 72% obese, or a 72% overweight and obesity rate. So yes, our environment has changed and we've got to change with it. We track these things. Metabolic syndrome is everything that kind of surrounds obesity, everything that goes with it, diabetes or high blood sugar, high blood pressure, high cholesterol. This is from just the Blue Cross Blue Shield State of Mississippi website. I was trying to find something that would show, you know, when we go have our healthy year, we go have our physicals, that's what we're looking at. But what are we doing with that information? We're not using it for prevention. We're just tracking it and we're watching it go up. So this is most of the facts that I'm giving you is from the Mississippi Obesity Action Plan that the State Department of Health put out in 2018, which I think is an excellent document. I don't know what we're doing with it, but it's an excellent read. Over the next 20 years, Mississippi's obesity rate is expected to contribute to over 400,000 new cases of type 2 diabetes, over 800,000 new cases of heart disease and stroke, over 100,000 cases of obesity-related cancer. So the obesity-related cancer is one thing that I really didn't realize until years ago when I started really treating obesity that was something to be concerned about. But about 40% of cancers that are diagnosed in the United States are associated with obesity. Overall, we're seeing a 13% decrease in our obesity rate. In our cancer rate, but we're seeing a 7% increase in those cancers that are associated with obesity because we're seeing that obesity rate go up. And also, I think that these patients are not offered their age-appropriate screenings. They get poor quality health care. We have research that shows that. I'm not going to go through each one of these, but there are over 200 comorbidities that are associated with obesity. Osteoarthritis, hypertension, diabetes, stroke, also anxiety, decreased work productivity, increased work absenteeism. I'm going to focus on diabetes because that's probably the one that we're most familiar with being associated with with obesity. The CDC thinks that we have about a 30% pre-diabetes rate in Mississippi, whether that's diagnosed or not. So they believe that we have 600 to 700,000 Mississippians that are on the path to developing type 2 diabetes. Diabetes is expensive to treat. So it's right at $17,000 a year to treat type 2 diabetes. But let me tell you what we see in our clinic. These patients don't just have diabetes. They have hypertension. They have high cholesterol. My adult patients probably are looking at a $30,000 knee replacement. They probably are looking at a very expensive first or second heart attack or stroke. It's never just the diabetes. We could treat all of those things at one time by treating obesity. About half of Mississippians that died in 2016 died of those leading causes, those heart disease, cancer, stroke, diabetes, hypertension, all of those associated with obesity. So we can either watch those numbers increase, or we can do something to get ahead of this with prevention, with aggressive lifestyle therapy, in addition to medication, bariatric surgery for the appropriate numbers, appropriate patients. I know that while y'all are listening to me talk, you're seeing dollar signs roll in your eyes. I want to talk about that too, the costs related to obesity. It's a 40% increase in healthcare costs when we look at a person that is affected by obesity versus not. In 2008, Mississippi spent $925 million in healthcare dollars as directly related to obesity. I know 2008 was a while back. That's the most recent data I could find. We probably don't want to know what that number is now. It's estimated that about 8% of the Medicaid budget is directly related to obesity. And Medicaid and Medicare kind of get lumped together a lot when we're looking at these studies. They pick up the brunt of this healthcare cost. So about 40% of that 69 million is associated directly with obesity. I want to talk a little bit about workforce costs. We know that as the BMI, or the body mass index, goes up, the work absenteeism also goes up. For people that have a BMI over 40, on average, they miss at least 7 additional days of work per year. In work productivity loss costs, we can look at 13 to 26 billion a year annually across the nation. I bring that up because my concern is these Mississippians that are affected by obesity and have all these chronic conditions and are more likely to miss more work, it's probably going to be harder for them to find and maintain employment. I'll give a personal story. When I was 23, I was a waitress at the Outback on 55, and I was pregnant, and we didn't have insurance. So we were on Medicaid, and I'm very thankful and grateful for that assistance. And I'm very thankful that I'm off of that assistance. So I feel like we're not setting these kids up to be able to get off of this assistance. All right, I want to talk about standard of care too. I think that a lot of times people think I'm over here practicing voodoo or, something of the sort, but this is evidence-based practice that we're doing, comprehensive treatment. All of our evidence-based guidelines promote dietary changes, lifestyle modifications, progressively increasing physical activity and exercise has the cornerstone of any type of comprehensive plan, but also pharmacotherapy and metabolic surgery when it's appropriate. I'm going to go back to this Mississippi Obesity Action Plan from the Mississippi State Department of Health that I think is so great. It actually has a goal for us to educate and encourage healthcare professionals to adopt those standards of care and to promote prevention and treatment of obesity to help our patients achieve and maintain a healthy weight. I don't know what we're doing to get to this goal, but we're not there yet. There are many options for non-surgical options for weight loss. Some are older. Some of these are FDA approved for 12 and up, and in Sivry, the rare genetics 6 and up. So we have options that would help our pediatric population. The medications that we've had in recent years that have come out have been more effective than anything that we've ever seen. When you compare it, if you compare bariatric surgery in terms of total body weight loss, not excess body weight loss like we generally do, it's pretty comparable in what we're seeing in these new medications that have safety data that go along with them. Like Whitney was saying, 5% is where we start to see major changes in health, but that's also where we start to see improvements in healthcare costs. So look at our newer medications and how effective they are. And we have some high responders that might even lose over 10 or 20%. So if we're seeing healthcare dollars go down at 5% and we're seeing health improvements even at 2.5%, imagine what 10 or 20% would do. That would be life-changing for some of these children. I tried to find something from Mississippi Medicaid to kind of see what we've done in the past. And I did find this chart. It looks like overall we're increasing our efforts on counseling, nutrition, and physical activity. And I think that's wonderful. But we're also seeing that obesity rate steadily increase. And we're also seeing, I imagine, healthcare dollars increase. So our current plan is not working. We need to add something to it. I'm going to give you one of my patient examples. This is a 48-year-old man that came to me with diabetes and high cholesterol and borderline high blood pressure. And thank God he had diabetes. And yes, Christy Davis from the Diabetes Endocrinology Clinic said, thank God my patient has diabetes because I can help him. These medications, the newer ones that we're talking about, are FDA approved under one brand has diabetes medications and another brand has weight loss medications, same medication class. So he had a BMI of 35 to start with. He could have gone for bariatric surgery, but he did not want to do that. He's been able to do several things to lose weight in the past, and he does try to exercise. He is a working professional like all of us, so he does tend to eat out more than he should, or he did. He's a dentist, so he doesn't drink sugar-sweetened beverages, which I think is the devil, in case you haven't noticed. And so he's done all he knows to do. A little backstory on him is he was diagnosed with a medical condition at age 18 and put on prednisone. That's a steroid that promotes a lot of weight gain. Somehow he was on it for 20 years. That's what we do. We put people on medication. We never take them off. That's my favorite thing to do, is take them off. By the time I got him, he was off of his prednisone, thankfully. And I'm sorry, this is a terrible graph but this is copied and pasted directly from my electronic medical record. And what you'll see is he went from a weight of 237 pounds down to 188 pounds. And also that his blood pressure at the top is the most recent. His diastolic blood pressure improved without adding any medication. I've got his hemoglobin A1C. That's how we measure diabetes. And he started at 7.3%, not terrible. He was on metformin, but not at goal. We want him at 6.5. And we got him down to 5.2%. And then his cholesterol numbers are below that. Once again, the first column is our most recent. The last column is where he started out. Those first, under his medication list, those first two things there are just his diabetes testing supplies. The only thing he is currently on is Ozempic, which, once again, one name brand is FDA approved for diabetes and the other FDA approved for weight loss. I couldn't have gotten him the weight loss one, unfortunately. And that's kind of where we are now. We have to wait on these kids to have diabetes before we can treat them. We can't get ahead of it with prevention. He's lost 49 pounds in about a year. So that's about a 20.7% body weight loss. That's phenomenal. If you look down a little bit further on the medications that he's not taking, because some of y'all were probably looking at those cholesterol numbers and saying, not a whole lot of difference. LDL is even a little higher, still all at goal, but he's off 2 cholesterol medications that he had been on for 20 years. He's off his acid reflux medication. And I took him off its metformin because he was having GI side effects with it, and nobody wants their dentist to have diarrhea in the middle of the root canal. So he is a very, very happy person, though, with his once-a-week shot and almost 50-pound weight loss. I could stand up here for hours, and I won't, but hours to talk about our barriers of treatment in Mississippi, about food deserts and lack of access to dietary education. I could talk about lack of access to transport and financial issues, but the big one that stops us before we can even get there is lack of insurance coverage for the treatment options. And that's what we need y'all's help with, so we can stop sitting in those exam rooms and handing tissues out and saying, I'm sorry, I can't help you. I want to look at the potential impact of treating obesity, once again, from our very own Mississippi Obesity Action Plan. And this is from 2018. If the body mass index of Mississippi were lowered by 5%, we would save 6.9% in healthcare costs. So they equate that to being about $6.12 trillion by the year 2030, just in prevention. So we would be able to possibly prevent over 80,000 cases of type 2 diabetes, possibly prevent over 60,000 new heart attacks and strokes, possibly prevent almost 5,000 obesity-related cancers. And then the cycle that I talked about in the beginning of my slideshow with adults that are adolescents that grow into adults that have weight issues, that have children that have weight issues. If we could treat these children and along with the adults, we could see that pattern break. Just a little bit more about the potential impact of treating obesity. Once again, at 2.5%, that's where we start to see changes. 3% is where we start to see blood pressure improving. 5% is where we start to see clinically meaningful weight loss with healthcare dollars saved and also big improvements in health. But if you look down at the bottom there, about 16%, which is where we are with our anti-obesity medications, our more recent medications that have come on market, we start to see reductions in cardiovascular heart disease. We start to see reductions in mortality, literally life-saving medication. So we have some recommendations, and this is actually from the white paper from the American Health Organization on recommendations for state policies, and that is to cover adult and pediatric weight management services, access to dietitians, anti-obesity medications, bariatric surgery. The whole report link is right there, but we've got to add something. Once again, I know y'all are seeing dollar signs just rolling your eyes, so I do want to talk about all this fear mongering about cost of these medications. Just some examples. People don't want to treat obesity. They don't. Medicare has a benefit for intensive behavioral therapy. Less than 1% of them actually use that. They also have a benefit for bariatric surgery. There are 22% smaller odds of them having surgery versus people that have commercial insurance. It's just not offered to them. There are other states that have had Medicaid come up with a plan to cover some of these services, if not all of them. And then also, I don't know how aware people are of this, but the Mississippi Board of Medical Licensure and Mississippi Board of Nursing have a lot of regulations on who can provide this service and limit that. So if over 30% of a provider's patient population or are on any type of anti-obesity, anything, any type of weight loss regimen, or if they advertise for weight loss, then they have a lot of extra things they have to do. They have to do 100 extra hours of obesity-specific CME. They have to have an application to the Board of Medical Licensure, and then they have to do 60 additional hours of obesity-specific CME or continuing medical education every 2 years to renew that. Y'all, that's a lot of stuff in addition to what we already have to do to keep our licenses current. So I think that risk of excessive prescribing can be mitigated. Most insurances that do cover anti-obesity medication require prior authorizations. I'm in an endocrine clinic, she's in a pediatric specialty clinic. We do prior authorizations all day for everything. The way that TRICARE does it is they have to have a prior authorization to start the medication and meet criteria. And then every 4 months, we have to repeat that prior authorization to show that they are showing progress. And if they're not, and they haven't met a certain percent of body weight loss, they don't get to stay on the medication. Specialists like us, if they weren't meeting progress and we couldn't change the medication or adjust the dose, we would stop it anyway. But you could put a hard stop in there on the prior authorization. You can require that only certain specialties. Blue Cross Blue Shield of Mississippi did this a while back with a expensive cholesterol medication. Only certain specialties were allowed to go through that prior authorization process. And you could do, you know, internal medicine, endocrinology, pediatrics, obesity medicine. You could even consider having a registry for pediatric obesity specialists. I can tell you it'd be a waste of your time, but you could consider doing it because nobody wants to treat obesity in pediatrics, just the specialists. That's why we're here, begging for help. One thing that I would throw out there, though, I would require that there would be some in-office comprehensive component to this. I think what we've seen in other drugs that have been overprescribed have been issues with, and there is definitely a place for telehealth and telemedicine, is that, you know, you go online, you fill out a little short questionnaire, and then you get your prescription, and that's it. That's not what we do in our clinics. And so I think having some type of stops in there for prior authorization would help. We recognize that we need more than just medication coverage. We definitely need policy changes to increase awareness about this obesity epidemic and regulate food advertising, targeting these kids. And, you know, we need to improve school environments. And there's some data out there that there would be a lot of benefit to taxing sugary drinks. But what we can do about in our clinic as specialists is we can help these patients that need it the most if we have access to the tools to help them. So just to summarize, make sure we all understand, obesity is a chronic disease. It needs to be treated. There are over 200 comorbidities and 13 different types of cancers that are associated with it. We need to have the right tools to treat the root cause of all of these different conditions. There are multiple clinical practice guidelines and recommendations to treat obesity, and we're trying, but we need y'all's help so we can treat it effectively. We've got to be able to eliminate the bias. And I think that truly is the root cause of why these things are not covered and why we don't have better efficacy in healthcare for these patients, is bias and discrimination for patients that are affected by obesity. There are definitely strategies that we can put in place to help reduce the costs or prevent, you know, opening the floodgates and overuse of that benefit, but we've got to have something. We got to start somewhere. And we also just need to really think about that overall cost of not treating it, the cost of not treating obesity and just continuing to ignore it so that we can treat downline all of these things, stroke and hypertension, diabetes. The cost of obesity is killing us as a state financially and literally, and we need y'all's help. I thank y'all for your time and attention, and we would be glad to answer any questions at all.
Thank you, Dr. Davis. I've got several questions. Did I understand, you had a slide that talked about, you know, once you're overweight, are you always going to be overweight even though, or you have that propensity to be overweight?
Well, so it is a chronic disease, and we do expect that you will always have those hormones that are fighting against you. There's some data out there that your set point may be lowered by surgery or after you've maintained your weight for a certain time. But the general answer is yes, you're always going to fight against that. When someone has cancer and we cure it, we don't say it's cured necessarily. We say it's in remission, right?
Right.
So we may be able to put the obesity in remission, but it's going to be something that we'll always have to monitor and make sure that we stay on top of.
So that sort of tug of war slide that you had kind of indicates that once you do lose the weight, you're going to have to continue that lifestyle change.
Absolutely, yes.
And, moving off of that, you're going to get backslide basically.
That's right. I tell my patients, there's nothing we'll be able to do here that'll be temporary. Whatever we do, this is your new lifestyle. It's got to be sustainable.
Earlier today, we had some presentations on postpartum care. And I'm just wondering, does gestational diabetes have an impact in the fetus and then the young adult, moving forward?
Absolutely. And, on the young adult and the mother, we know those that are affected by gestational diabetes are more likely to have type 2 diabetes later in life. And if all of there's a really long answer here, but the answer is yes. There's a lot of complications that fetus will, if they don't have a miscarriage or they, don't have any issues. Probably they'll be large for gestational size, 9, 10, 12 pounds. And that causes a lot of compression on the placenta and issues in itself. And it just snowballs before the baby's even born.
You mentioned there was a lack of insurance coverage. Is that globally all payers or?
No, there's definitely some pockets of insurance coverage. Generally about 30% commercial, I think, coverage. It's getting better. Larger companies cover. I think Tennessee Medicaid possibly, and some of the other states have coverage. It's becoming more common for it to be covered. I'm hoping that we won't be last.
And how do we do from a Medicaid standpoint with coverage?
Oh, nothing.
Well, for services, clinic services, it's good, but medication, nothing. No coverage.
So I'm sorry, you said for clinic visits?
Yes.
It's
So
covered?
paying for the visit to come and see me, yes, covered. Dietitian services, it depends on whether it's fee for service or managed care. It seems to be different. For medication coverage, it's 0.
Is there a reason for that?
For the medication or the
Right, for the Medicaid, for not.
well, it's the anti-obesity medication is not on the formulary currently, and so it's all self-pay.
Someone mentioned that no one wants to treat adolescent obesity, and why is that?
It's very difficult.
Obviously, if you're Medicaid, you're not getting paid, but other than that.
Well, I think that it's for several reasons. They're in pediatrics, just like really any other medical office, it's very, very busy and you're focused on wellness care. And it is in some ways a focus in terms of encouraging and addressing lifestyle issues, diet and exercise issues, but it falls to the bottom in terms of in-depth care. And so it really takes a lot of time and effort to treat obesity, and it has to be frequent visits and accountability partners and looking at all of the things, labs, other services that are needed. So in terms of medication, I would say pediatricians in general are not comfortable at all. And I understand that, but I think, kind of like Christy said, it gives us a better way to help them in our clinics. And if we were to be covered for medication, we are specialists, we are comfortable with this, and we're the best place to treat them. Because of that discomfort, those pediatricians in the state are not going to be trying to prescribe these medicines because they're not comfortable with them to begin with.
Are you aware of other states' Medicaid programs cover medications for obesity?
I believe Tennessee. And
Right. Would it be possible for you to get us some documentation on that? Right. And then I think my last question is, you mentioned the medical licensure board. Seems like they may be creating hurdles. Could you expand on that a little bit? What you mentioned the role of the medical licensure board, and apparently you have to go through a lot of additional training and
Lots of hoops to jump through. So in my clinic as a nurse practitioner, I do all of the obesity management in my clinic. And my collaborating physician, Dr. East, Honey East, is licensed under the Board of Medical Licensure. And because we advertise, there's a sign on the front door, and we do weight management, she had to do 100 hours of obesity education separate from what she has to do for her other certifications. So for internal medicine, for example, I think it's 40 hours. So every 2 years, she does her 40 hours, and then she has to do 60 hours. And I do the same just because I feel like it should be the same. So it's extra hoops to jump through, and I'll just say it a little more plainly than Dr. Herring did. We're not making any money off of this. It'd be a lot more, from a business standpoint, it'd be a lot more lucrative if I was not doing obesity, if I was not spending that additional time and staff tying them up, doing prior authorizations and educating patients. And it's a lot of hoops. It's a lot of things to go through. And in primary care, they've got a lot of other issues that they need to deal with. They're putting the fires out. We're wanting to do some prevention.
Are you aware that if, other states have to have the same type of continued education?
So that varies widely. Some do and some do not.
Do any committee members have questions? Yes, sir. Senator Polk.
Thank you, Mr. Chairman. I'd like to go back to one of your slides about the cost. If we could save, I believe it was 5% on the weight factor, we could save 6.2 maybe trillion dollars in 8 years.
That was from 2018, so it's a little behind, but I wanted to use this because this is from the Mississippi State Department of Health. This is our data.
Could you show me that slide?
Right here, sir.
Oh, okay, 5%, 6 trillion by 2030. Trillion, not billion,
Yes, sir.
in Mississippi only.
Yes, sir.
I didn't know we spent that much on medical anything.
Well, if you add it up over, I guess in 2018, it would have been 12 years, and probably the data is, I imagine, a little older than that by the time you get to writing it up. So let's say over 15 years, and you start thinking of those over 200 comorbidities, maybe they're expecting it to add up. But this is what the Mississippi State Department of Health says.
Okay, thank you.
Any other questions from committee members? Thank you, ladies. Appreciate it.
Thank you.